Hi, good evening, everyone. Thank you for taking time out on a Thursday evening to spend it with us folks here at Digital Futures Lab and our lovely panelists as we attempt to both pick apart and put back together our hopes and visions for the role of GenAI in the future of healthcare in India. My name is Sasha John, and I'm a researcher here at Digital Futures Lab and the project lead for the project that we are discussing today, Human in the Loop. For those of you who don't know us, Digital Futures Lab is an independent interdisciplinary research studio that studies the complex interplay between technology and society in India and the majority world. Through evidence-based research, systematic foresight, and public engagement, we work to realize pathways toward equitable, safe, and sustainable digital futures. Human in the Loop sits squarely at the intersection of all three things that DFL does. It is a participatory foresight and storytelling project by Digital Futures Lab in collaboration with Quicksand and supported by Rohini Ninutini Philanthropies that explores the unintended consequences of generative AI in India, focusing not just on the potential of the technology, but on the hidden risks that often go unseen. So much of the work on reining in or advocating for GenAI's rapid advancements is based very nearsightedly on the risks and benefits that we see playing out today. The future forest that we're missing for the trees is one replete with harmful technology and policy lock-ins if we don't think critically about the unintended consequences that may come up as a result of this technology and the ways in which it is developed and deployed. Human in the Loop attempts something quite big here, which is to close the gap between what could happen in the future, what's possible, and what we should actually want for our future. So our approach to the project has been twofold, right? Building speculative scenarios based on research and foresight, and bringing those scenarios to life through illustrative storytelling. So foresight is about spotting signals early, questioning our trajectory before paths become one-way streets that we can't U-turn out of, and thinking through multiple desirable pathways that we could build instead. We conducted these foresight exercises internally and in collaboration with experts and people who responded to our open call for stories, piecing together insight, anecdotes, and data to form the imaginations and provocations for future pathways. The narratives that came out of both the expert consultations and through the open call surfaced both immediate impacts and slower, often invisible shifts in agency, relationships, and social norms. We chose illustrative storytelling not as like a fancy way to get this project out there, but as a necessary reframe. We believe that stories bring nuance in a way that traditional policy reports and long white papers might not be able to, especially in an engaging, tangible way for various audiences, from like academics and policymakers to a general audience who these technologies impact. And DFL worked very closely with the artists for each of these stories to ensure that the provocations and insights that came out of our research and out of our consultations really came through in the way the story portrays the technology trajectories, tipping points, and resolutions. In an age where technology is evolving faster than our ethical, social, and ecological frameworks can keep pace, the narratives in Human in the Loop serve as guideposts of what could become of us. We hope that these stories cultivate a longing for futures that center human dignity, planetary care, and equitable technological progress. Without such glimpses, I think we risk hurtling towards futures that don't serve us, futures that might be more extractive, isolating, and unjust than the present. The stories in the series cover a range of sectors and topics: agriculture, judiciary, healthcare, and environmental impacts are some of the stories that we've covered as the first part of this project. And coming up soon, we have ones on companion AI and agentic AI. Today, we're focusing on our story on healthcare, The Wandering Healer, illustrated by the incredible Damini Gupta. This is Nandini, a community health worker in 2035. She's loosely based off of Anganwadi and Asha workers of today. She suddenly handed the Sahara Superband 2.0 a shiny new GenAI tool promising great efficiency gains. This sounds helpful enough and sounds very similar to what most trajectories of technologies that are introduced in these spaces might look like. But like any good story and like any technology innovation trajectory, this one takes quite a turn. The GenAI device lets Nandini visit more patients per day, but soon it morphs into quite the pressure cooker situation. Reminders ping telling her to move on from patients, quotas increase. Providing care now means making her way through a checklist. Nandini's deep relational connection with patients built over time begins to unravel. An encounter that illustrates this is when Rekha, a woman hoping for a child, senses Nandini's compassion obstructed by the tool's rigid schedule and lack of sensitivity. Care work starts to feel really transactional. But, and this is the pivot that we want in our technology trajectories and even in our stories as part of this project, we imagine a different pathway. Nandini repurposes a discarded medical robot to create those, an older model AI system redesigned around an ethic of care. Here, the system respects invisible labor, values follow-ups, empathy, and considers aspects often unaccounted for in a health worker's day-to-day, like travel time and the emotional weight of being somewhat responsible for community health. The story asks, who should AI serve and how should we serve them? Efficiency at the cost of empathy or systems designed to uplift human care. It invites us to rethink what GenAI can and should optimize for. Not speed, but perhaps compassion, and not making our way through checklists, but strengthening how we provide care. I hope I've built enough intrigue about the story that you all will check it out after this panel at loop.digitalfutureslab.in or at the QR code on the screen. I also hope I've set up enough context for the themes we'll be exploring with our panelists today. All of them are people we have had the honor of working with time and time again on various projects, including this one. And so now I hand over the mic to our moderator for the evening, Arshi Gupta, to introduce them.
Today, we've brought together a remarkable panel whose work spans clinical practice, AI development, product strategy, as well as public policy, exactly the kind of perspectives we need to think across systems, tools, and lived realities. Let me quickly briefly introduce them. I'll start with Amrita. Amrita Mahale leads the product strategy at Arman, a nonprofit that leverages mobile technology to improve maternal and child health in India through programs like Kilkari and Mobile Academy. In her role, Amrita shares the vision for these large-scale digital health platforms using iterative, evidence-driven, and human-centered design. She's previously worked at Wadhwani AI, Google, and the BCG, trained in aerospace engineering at IIT Bombay and Stanford. Great to have you, Amrita, here. Next, we have Smriti Parashira. She's a lawyer and independent researcher working at the intersection of tech, law, and society. She's the editor of the book Private and Controversial, a foundational volume of privacy and public health in India. Smriti has worked with NIPFP, UNDP India, the Competition Commission of India, and FGV Law School in Brazil. She studied at NLS Bangalore and University of Pennsylvania and is currently pursuing her PhD at IIT Delhi. Next, we have Dr. Shrey Desai, who's a clinician and director of research with Seva Rural, where his team develops and implements public health solutions for tribal communities in Gujarat. His published research spans mobile health interventions for maternal and child health, models for managing undernutrition and menstrual hygiene, and digital tools for depression care. And finally, we have Alpan Raval, who is the chief scientist for artificial intelligence and machine learning at the Wadhwani Institute for AI. He's previously led applied AI teams at LinkedIn and Amazon, served as research staff at DE Shaw, and was a tenured faculty member at the Claremont Colleges in the US. His work spans healthcare, agriculture, and biological networks and brings a deeply technical with socially grounded perspective on how technologies are integrated into many of these critical social sectors. On behalf of Digital Futures Lab, I extend a warm welcome to all of you. And with that, let's quickly move into the discussion. Now, across different sectors, we've seen generative AI being increasingly positioned as a transformative force with tools that can support everything from medical diagnosis to decision-making to documentation, triage, as well as patient communication. Within healthcare, this promise of generative AI and other state-of-the-art AI tools translates into faster access to information, more consistent clinical reasoning, reduced workload for a lot of the healthcare workers as well. But what happens when this same logic travels to community healthcare work and frontline work, to community workers, ASHA workers, ANMs who are already navigating some of these fragmented systems, limited sources, and almost always have their labor chronically undervalued? What we see in The Wandering Healer, we meet Nandini, who is ASHA worker and whose AI assistant called the Sahara Super Band initially helps her cover more ground, cover more patients, and respond more quickly to patient needs. But over time, the tool also begins to dictate her pace, monitor her time, and redefine what counts as care. And this shift from augmentation or assistance to optimization, from help to control, raises a lot of urgent questions. Who defines what generative AI should do in public health? Who benefits the most? And what should we really be optimizing for? Whether it's speed, consistency, coverage, or is it about care, trust, and dignity? So, with this quick backdrop, I want to quickly delve into the first question, and perhaps to open the conversation, Alpan, I can bring you in, since so much of the debate starts with how these systems are built and engineered. When we talk about AI in the public health space, the conversations centers around speed, coverage, and a lot of the efficiency related metrics. Even the wandering healer gives us a very futuristic glimpse of what happens when we continuously chase some of these metrics. But I want to pull us back to the present in terms of how currently generative AI tools are being deployed within healthcare and the dominant logic that underpins this deployment. Especially in your work of building some of these systems, how are these trade offs between efficiency versus care optimized for or almost resolved when you design and engineer models? And perhaps if you could share an example with the group, that would be super helpful. Over to you, Alpan.
Thank you, Arushi, for inviting me to this panel. Very pleased to be discussing these aspects with my fellow panelists here. And it was also fun to go through the Wandering Healer comic. I think it was very well made. So I want to sort of firstly dispel a few myths. I mean, I am concerned about the implications of sort of uncontrolled, untrammeled AI, but I don't think that GenAI tools are necessarily optimized for efficiency at all costs. And certainly in our work, we don't optimize for efficiency in a sense. We do optimize for the accuracy, the factual accuracy of the response, but not necessarily efficiency. And there is a whole framework of responsible AI evaluations and metrics, like checking for toxicity, fairness, bias, hate speech, and so on, which of course are are sort of a superset of the metrics that may be relevant for the specific case of the Wandering Healer. But in essence, what these metrics try to capture is whether the output of the AI is palatable to the person using it, right? You cannot sort of optimize in a general context. You have to optimize in the context of the people who are going to be using the AI. But in spite of all these guardrails, so you may sort of fine tune, and there are ways to fine tune these models for these various metrics. But even with all of these guardrails, fine tuning, optimization for factual accuracy, and so on, making sure the AI acts quote unquote responsibly, even though this word is sort of, I think, used too often. Even with all of this, it has to be used as you correctly pointed out earlier, or I think Sasha pointed out earlier, it should be used in a human in the loop setting, especially in the healthcare space. You cannot let these models sort of take decisions on their own. So it's the human that should make decisions. And from a technology standpoint, it's fairly straightforward to solve this problem and optimize these tools so that they create outputs that both patients and healthcare workers find satisfactory. So this can be done through prompt engineering, fine-tuning on specific QA datasets that are well designed, where the responses are much more human, and eventually using tools like reinforcement learning with human feedback, where the human feedback comes from humans who matter, the people on the ground. You can evaluate on these sort of chain of utterance type conversations where you create a simulated conversation between a health worker and the patient, and you tell the AI that this is the kind of conversation we want to see, and you also show it hard negative examples of conversations of the type that you don't want to see, which were highlighted, for example, in the first half of the Wandering Healer. And you can train the AI to respond in a way that sounds empathetic, right? And we should also keep in mind that we are not necessarily talking about general purpose LLMs or GenAI here. So it's much easier problem to solve for a specific domain, that is healthcare. We can train LLMs to not respond to situations outside this domain, as the bot was doing in your Wandering Healer write-up. So it really should not respond for things that are outside the healthcare domain. And these are not, these are solvable technical problems. So in a sense, they are not technical problems, they are human problems. The human has to decide what to use and design the LLM-based tool for and what to prioritize. So the picture that's painted here, I think, is a bit draconian. It's very similar to the old days of the Industrial Revolution. So if you've seen, for example, Charlie Chaplin in Modern Times, you know what I'm talking about, where assembly workers have no autonomy and their lives appear to be dictated by the machine. But really, they were dictated by humans behind the machine, not by the machine. And we've seen that play out over the years, where when humans with better policy have changed how they want to use the tool, then these tools can be used well. And so I think this is a very similar situation. This particular problem, I mean, I can talk later about other problems with GenAI, but I think this particular problem is solvable provided the humans at the top want to solve it. So humans shouldn't deploy models to make them more efficient, right? They should deploy models so that they solve the problem at hand, which is the healthcare problem, and which is to make sure that the patients have trust. And you should have human in the.
Yes, absolutely. Coming back to our main punchline, and that's actually a really powerful point also in terms of ensuring that the models are engineered in a way that are contextually relevant, both in terms of the outputs they're presenting as well as what they're exactly optimized for. And I also wanted to continue on that thread that you pointed out around the value of involving humans right from the very beginning, which is making top level decisions right down to the deployment stage. And perhaps, Shrey, this is where I bring you in as well, based on your field experiences of having seen a lot of the deployment of many of these digital health tools in the field within Gujarat. What would be the key insights and lessons that you've seen when many of these digitized tools are integrated into last mile delivery of public healthcare systems, particularly focusing on how they impact the workload, the kind of workflows that we see at the frontline care level? The dominant rhetoric around generative AI tools that are currently being designed for frontline health workers is they reduce the work burden, they optimize their workflows, and also provide them with the right tools when they're interacting with the patients. What kind of impact have you really seen of either the generative AI tools or any of the recent similar digital health interventions that we see at the frontline?
So this area is very close to our hearts. So thanks for having us in this discussion. And more than a decade ago, my organization, Seva Rural, a grassroots NGO in southern part of Gujarat, we have been involved in the delivery of primary healthcare services in rural tribal areas for now more than 4 decades, actually. So for first 35 years, primary healthcare services were delivered in in a traditional manner through paper registers, and you know what I'm talking about. But and there were a lot of lessons learned. We had fantastic results and patient outcomes through those projects in those on those early years. And what we realize is that when the frontline workers are supported well and supervised well, they can do wonders. And that was our inspiration of bringing technology piece, that how technology can not just supervise, but also support the health care workers so that we can get better health outcomes. So technology as a job aid rather than job add, job AID aid rather than job add, which is ADD, was our kind of mantra when we started. And when we started, we were very hopeful that many of the challenges at scale would be overcome through use of technology, such as digitizing care protocols, digitizing new lists, and so on and so forth. And you know what? Actually, many of those things really happened to improve health outcomes in our project area. Because the health workers were aided by digital technology, the infant mortality rate came down, maternal morbidity also came down. But at the same time, we saw certain very interesting developments at a personal level from the frontline workers' lives. So I'll give you 2, 3 examples. One of the things that happened is because the care protocols and the reminders were digitized, the health workers found them quite exacting. That these are, so many reminders, so many patients to kind of see in one day. This is unmanageable. And well-meaning, hardworking health workers sometimes, had to, end up fudging the data just to show that the work is or the reminder is closed. So that was one interesting experience. I think, and Nandini, in the case study that has been written, something similar happens in her case as well. Second series of things were at domestic end, where the husbands, and these were early days, I'm talking about 2012, 2013, 2014. Smartphones were just trickling into our lives. And the husbands of those frontline health workers, started, becoming suspicious that, why my wife is on phone for such a long period of time, whom she is talking to or texting. So there were some tensions on that front as well. And frankly, there were quite a few, lazy health workers, a small proportion, but, they were not interested in working. So they had to work really hard because the digital interventions came into being. And that also actually caused, tensions between the program team and the health workers. However, I want to kind of underline one particular word that was very useful to us to overcome this challenge in a very humane way was ongoing listening and iteration. Ongoing listening to the health workers, looking live the world through their eyes and what they are experiencing, what are the legitimate concerns, and trying to overcome through technology or non-technological means. So, for an example, at the domestic front, to alleviate the concerns of the family members and the husbands, we organized a Pati Sammelan. Pati Sammelan is, get together of all the, husbands, making them aware about what's happening, having some good food, and that built the confidence to sustain the work. Now, when the reminders were becoming too exacting, we listened to the health workers and tried our best to reduce the number of reminders to make it manageable without compromising the quality of care. So I think what I would like to hone in is it's very important to continue to listen to the health workers, their personal stories, why we worked rigorously at improving health outcomes. We have to arrange a wedding between efficiency and their personal, challenges. And I think that would give remarkable results. I don't see both at kind of at friction. I think we can make both work at the same time. And I'm glad that your organization is bringing these issues at a very timely manner so that we can design, many of these things that we are doing with AI now, balancing both.
Super. Thanks so much, Sri. And I think that's a very critical point in terms of the value of community engagement when designing a product such as like a generative AI chatbot or designing any product for community health workers. And I think there is a lot of discourse around the value of human-centered design, around community engagement. But what I haven't seen a lot in the conversations is the minutiae of doing community engagement. It's hard work, it's iterative, it takes a lot of effort. And perhaps, Amrita, this is where I pull you in as well, based on your experience of designing a product for community health workers, particularly ANMs, and the kind of feedback loop you had with that target user base, whether there were in terms of any tensions or friction points that were voiced by the community that you then took back to the whiteboard and reconfigured the system that you were designing. Any examples, or perhaps just sharing with us the process of doing community engagement, right?
Yeah. Thank you so much, Arushi. And I will try and bring in a product and design perspective to my answer. So at Arman, a key feature of our overall model and approach is what we call tech plus touch, which means recognizing what technology can and cannot do and rooting interventions in the care empathy, insight that only human connection can bring, right? And tech plus touch is almost, I mean, it could be the title of the end of the story as well. No spoilers, but it is a happy ending. And more tactically speaking, for us, for any new digital product that we develop, we start by asking ourselves, what is the problem we are trying to solve? Whom are we solving this problem for? And what is their articulation of this problem, right? So we spend a lot of time talking to our users, and sometimes a problem is in most cases, problems are multifaceted, and what the user wants, what the user needs may not be perfectly aligned with what the system wants and needs. So there is some inherent tension in designing these solutions, and it requires a lot of deliberate choices. One way in which we do this is by making sure that the team that builds products is multidisciplinary, right? So we not only have product folks and designers, we have a program team, we have a content team, we have researchers who have far deeper backgrounds in public health than I do or any of the designers on my team do. But essentially, it all comes down to being very clear about what you're trying to achieve, right? At Arman, we know that we want to reduce maternal and child mortality and morbidity. And the path we've chosen to do this is through well-informed women and empowered, more knowledgeable health workers, right? So once you have this articulation clear, it becomes very obvious that efficiency is not a worthy goal to pursue in itself, and nor is the use of AI. You asked me about the process we followed to develop our A&M chatbot. So we have a high-risk pregnancy program in which, in addition to classroom training of health workers on the end-to-end management of high-risk pregnancies, we also offer them a digital learning system. And the digital learning system consists of a WhatsApp-based support system where health workers, more specifically A&Ms, can raise questions at the time of service delivery. So they've learned a lot through classroom training as well as through digital tools on how to detect, manage various high-risk pregnancies. But at the time of service delivery, if they have a question, we gave them access to a WhatsApp helpline where they could send questions. And for the longest time, it was doctors who were responding to these questions, but it was a process rife with friction. Right? Doctors did not often prioritize responding to these questions because they were a mix of learning doubts and actual case scenario style questions. And when A&Ms, found themselves waiting several hours to several days to get an answer, they stopped using the service altogether, or they just started picking up the phone and calling their supervisor, right, each time they had a question. And we saw an opportunity to use LLMs to make this process smoother. But before we rolled this out, we actually spent a lot of time with A&Ms trying to understand what exact use case would be valuable. And we decided to focus more on the learning support side than decision support because it reflected what the program needed, what the user needed. It was also safer. And even before we had a working product, we spent a lot of time doing Wizard of Oz experiments, right? So when I talk about user research, it's not just going and asking users, what do you want? It's also teasing out what they want through various research methods. And one of the research methods we employ is Wizard of Oz experiments, where we simulate an AI system, right? There's actually a human who's responding, just like Wizard of Oz, where there's a man behind the curtain. And this let us understand how, a GenAI tool will be used, perceived, interpreted on the ground. We saw very quickly that older A&Ms were not comfortable typing, detailed questions. So when we gave them scenarios, asked them to pose a question, when they chose text, they essentially ended up omitting a lot of information. But when we gave them the choice to use a voice note, the questions became more detailed, which meant that the answers also would become more effective. We gave them different answer types to respond to, and we learned that most of them actually preferred multilingual answers, where the body of the answer was in the local language, but key medical terms and numbers were in English because they often did not know the local language technical terms for various health conditions. Plus, even before we rolled it out at scale, we actually did some field testing, supervised field testing with a small number of health workers. We first rolled out the tool to 20 ANMs for a period of 2 to 3 weeks, where we could follow up with them about each and every question that came in. Then we increased it to 50, then 100. And only after observing this process for a few months, and after we built confidence that this was something that was working for users and could be validated by human experts behind the scenes, did we roll it out to 3 full districts.
Super. Thanks so much for the detailed overview of the process, Amrita. And I think you've highlighted two very critical points. One is, of course, the very suitability of a generative AI tool vis-a-vis the problem space, right? At many times, you're very quick to assess and almost use it as a foregone conclusion that, yes, generative AI is the silver bullet for this particular problem diagnosis. And of course, the second aspect is community engagement to map user needs. And perhaps, Smriti, this is where I bring you in as well. And you've written extensively about on the governance of emerging technologies. And I wanted to understand from you, if we have to abstract these sentiments at one level higher up, how do we really institutionalize these principles at an AI governance conversation level? A lot of the conversation around AI governance assumes that generative AI is good, generative AI is here to solve problems. All we need to do is manage the risks. Very few conversations happen around the very suitability of generative AI, and do we even need AI for this particular use case? And I wanted to understand from you, what would it really take to almost reorient the conversation? How do we move back the starting point and start critically questioning the very suitability of generative AI tools? Yeah, sorry if that's a leading question to begin with, but over to you.
Thanks so much, Arushi. Let me start by congratulating all of you for this fantastic initiative and for making, a story which all of us follow and understand in our work so accessible to everyone else, and attracting attention in a way that moves beyond the policy and the development circle. So congrats to the team for getting that done. On your question, I think that's exactly bang on the issue, that there are so many complex trade-offs that are involved in any of these deployment scenarios that we think of, and of course, there are principles that abound at the national level. Internationally, there are so many principles talking about things like privacy, talking about security, transparency, suitability, etc. And I think it's well accepted at a principle level, at least, that these need to be incorporated. The challenge is when the rubber hits the road, what are the frameworks that you need, and who are the actors who need to be incentivized or or otherwise in some way compelled to comply with this, right? And I think that's where the challenge is. One of the things I want to draw upon is the what in the feminist literature is called the standpoint theory, right? The starting point of realizing that all of us come from a certain place, the social groups that we come from, the experiences that we bring represent our worldview, right? So if you are in a situation where the worldview is that of a bureaucrat who's trying to think about a system that makes things more convenient, more efficient, is able to monitor intermediaries better, you will reach at a particular solution because your standpoint that you're looking at the problem from, and from that viewpoint, someone might think AI deployment or tech deployment more broadly is the right solution. But if you reverse that standpoint or broaden it, you ask from the community health worker standpoint, and you ask them, you're servicing hundreds of houses, you have these hardships, you're walking these long distances, what would it need for that to become easier for you? You reverse that standpoint, and then maybe AI is not the solution, right? So rather than asking how do we do it, it is, as you said, it's a whether AI question is what we need to be asking more fundamentally in a lot of contexts. And again, from the user's point of view, switching that lens to third lens, a lot of time, going to another theory which we use in the privacy literature often is of contextual integrity, right? So when a user is giving data to someone, they are worried they're giving it in a particular context, which is of getting a certain service, getting information from the community worker, but they don't envisage it being used in a third context, like we see in this story, right? When Nandini's friend finds that a loan is not being given to her by the bank because her health data has been used and they don't think she's a likely good creditor, right? So something like that, which is definitely define the contextual integrity of that interaction between the health worker or the health system and the individual, and then leading to, a mission creep in some way and misuse of data in a way which wasn't what the individual wanted. So I think there are complexities in all of this, and there is a nuance and it's hard to generalize, but I think eventually the question is about, are we ready to think about a regulation conversation? It doesn't have to be all out regulation in the way some countries are doing. I think there is a graded approach that can be followed, but so far at a policy level, we are not finding ourselves in a situation where we are even open to that conversation. The position seems to be that, AI is great, AI has all this advantage and benefit, and we don't want to stifle it through regulation. But we have to realize from the data protection conversation that it takes over a decade to, bring about a law. It takes a couple more years to even operationalize it. So if we really want to have even 15 years down the line a robust mechanism to, think about healthcare and AI more broadly, we need to start that conversation about thinking about these trade-offs and balancing them in a structured manner right now.
Superb, Smriti. Thanks so much for summing the contemporary status quo, so to say, of the policy and regulation conversation on AI so far. I want to shift gears a little bit here and perhaps move to what I think Smriti talked about as the standpoint theory, and perhaps coming to Alpan, you as from the perspective of a technologist. I'd imagine there are many challenges that you face that, yes, sure, there are, almost a checklist of principles of responsible AI frameworks that are there to be referred to almost as a ready reckoner for all teams. But once we go into the action stage of it all, a lot of the things fall through the cracks. It's difficult to implement many care protocols, many human in the loop protocols. And I wanted to understand from you, from your experience of building many such tools, what kind of barriers or stone walls have you encountered while implementing many of these RAI frameworks? And if there's any sort of nugget of wisdom or example that you want to share with the other AI developers in the ecosystem?
So we don't sort of take a framework and blindly implement it in a specific solution. Pretty much no framework works as it is in a specific. So you have to study what's happening on the ground. And in fact, we have experiences outside the LLM space where we've encountered various problems with deploying things on the ground, and I can get into sort of data issues. Solutions don't work because of lack of internet. You have to use small LLMs because, again, lack of internet, you can't wait for a cloud inference. And then the small LLMs are not as good, they're not as performant. So there are all these issues, and these are technical challenges that come up all the time. There are also issues where I think the main issue comes up when AI is not evaluated well. And I think this is almost a universal thing that I see and it seems almost an obvious thing, but it seems like a universal stumbling block, is that people tend to deploy AI models without evaluating them for the context in which they will be used. And it's the most simple lesson about AI. You cannot evaluate on ready-made benchmarks, right? Ready-made benchmarks are fine for publishing papers and so on. They're not fine for deploying an AI model on the ground. You have to understand what's going on the ground. You have to understand, for example, if you're deploying a LLM for a frontline health worker, which is, part of the work that we are trying to do at Vadhwani AI. We're developing this solution called Healthwani for frontline health workers. You cannot take questions, you cannot evaluate on questions that are taken out of some manual. You have to evaluate on questions that a frontline health worker would actually ask. And this seems like the most obvious thing, but when you actually look at these models and you evaluate them on benchmark data sets or on data sets that are extracted out of standard medical literature, these models do extremely well. But when you evaluate them on the actual questions that frontline health workers ask, ASHA workers, Anganwadi workers, and so on, in the language and in the intonation that they ask, they don't do very well at all. And that is the challenge. You have to adapt these models. You have to fine tune them for those data sets. But before you fine tune, you have to do the right set of evaluations. So, I always say, evaluation is at the heart of AI. If you have a good, robust AI model, there are probably very good evaluations behind it. And on the other hand, if you have a bad model, a most likely reason is that the evaluations haven't been done well and it's been deployed without a good evaluation. So this is in this specific context that, these are sort of practical on the ground challenges. But in the larger context, again, I'd like to go back to the wandering healer example. Everything is hunky-dory at the end. Because it has as Amrita said, it has a happy ending. The AI is actually used well. But to me, the real challenges start as an epilogue to the wandering healer. So many of, as I mentioned earlier, some of these challenges can be resolved with time, with work, and so on. You can make these models appear ethical. In fact, they are software systems. They're not ethical intrinsically, but you can make them appear ethical too, because you can design the responses, you can simulate the responses to appear ethical. And as Geoffrey Hinton recently said, we should design AI models that look out for human interests, even though these models may reason better than us, maybe more knowledgeable than us. And he compared it to a mother and a baby situation, where a mother knows more than the baby, but the baby controls the mother, right? So, and this is not my example, this is Hinton's example. And so we should think of ourselves as the baby and the AI is the mother in this limited sense, where the AI is designed and trained to look after the baby and protect it, rather than go against it. Now, this is fine, and this is sort of very nicely encapsulates the whole responsible AI story behind AI. But my problem is what happens next? What if the baby starts behaving like the mother? These AI models have their own inductive biases, and we do not yet understand the full space of inductive biases. For those of you who don't know what inductive biases are, they're essentially the biases that are ingrained within the AI, that don't come from the data, but that actually come from the algorithm itself, right? And in the early days of LLMs, we could all tell that, oh, this content was produced by an LLM versus this content was produced by a human, and that's the inductive bias at work, right? Nowadays, it's getting harder and harder to tell if content was produced by a LLM or by a human. So these inductive biases are becoming much more subtle, but they exist nevertheless. The AI wouldn't be able to do what it does without the inductive biases. It won't be able to generalize, generate new content, and so on. So the question is, what happens eventually after we use these models a lot, even if they are sort of subservient to us, they look out for our own interests, we will eventually start thinking like them and talking like them, right? We will inherit, the baby will inherit the inductive biases of the mother. And to me, that is the bigger challenge and the bigger danger. What happens at that stage? Where will humans go then? If the AI can be as creative as humans are today, will humans find a new path to be creative? Will they be able to do other things, or will they become so reliant and dependent on the so-called mother that they never grow up, right? That humans never grow up, really. And to me, this is, this sounds like an abstract situation, but this is a real challenge. You can already see among young people today who use large language models that they're beginning to talk, they're beginning to think. Just by designing prompts, they're beginning to talk and think like these models. And this is only going to increase. To me, that's the bigger challenge. What will the health worker, if these models really help them and do so well, will the health worker eventually, gradually, imperceptibly lose agency? To me, that is really, sort of a long-term challenge.
Maybe that could be part 2 of The Wandering Healer, where we go into and delve into the issues of over-reliance and loss of human autonomy. Amrita, maybe I can bring you in here again from a product perspective. And I wanted to touch upon a different dimension that Alpan briefly talked about, was there is this almost imperative, so to say, on ensuring that a generative AI tool that is being developed is scaled, is of course contextually relevant to the target user base that you're dealing with, but at the same time has potential to be scaled to other contexts, to other subpopulations within the country. And I wanted to understand from you if those tensions between care versus scale, right? Care and contextual sensitivity would require focusing, being hyper local about the design of the system, about the deployment mechanisms. And perhaps that is at odds with the scale logic, or the logic of sort of scaling and institutionalizing the product that you're building. I wonder if you've come across those tensions in your product road mapping for the tool that you're building.
Yeah, I would say there are many inherent tensions here. Scale is one of them. Just time and resources are two other constraints that are very critical. And I mean, we first started off with a chatbot for A&Ms in UP. And this was a Hindi chatbot. But even within UP, we had 3 districts. And we saw that voice performance in one district was better than the other two, right? And there are variations even within a fairly limited geography, which was tripping up the LLM. And there was a lot of pressure on us from the rest of the organization to take something that works and take it to other states. But I mean, I have spent a lot of time in the last few months pushing back against this, of course, while keeping the momentum that we got. Because what worked in one geography does not work in another. So when we took our UP chatbot, made a few tweaks, took it to Telangana, we saw that things that the model did really well in UP, it wasn't as smooth in Telangana because of the language changes. And some of it is not about product, it's just the underlying technology itself. Like LLMs perform better in some languages compared to others, and I wouldn't even consider Telugu to be a low resource language in the larger scheme of things. Our program is also live in Bodoland. I mean, I would have no confidence in taking the chatbot to Bodoland and having it work in Bodo. But Telugu is not even a low resource language. And yeah, I mean, I think it's important for the technologists, the product designers to push back and educate the other stakeholders in the scaling process, in the design process, that here are some limitations. Here is what you lose if you speed up the scaling. And I mean, it's also a question of safety, right? So in some cases, you may be willing to compromise on performance, but where there's safety involved, those tensions become more pronounced. If it's just about, some grammatical errors which will maybe dampen the user experience, those are trade-offs I'm willing to take. But if there are issues of accuracy or bias, then that's when you need to hit the brakes. Does that answer your question, Arushi?
Yeah, absolutely. And thanks for also just pointing out this difference between non-negotiables when it comes to safety of generative AI models versus things that we do have a workaround for are not as nefarious as lack of accuracy or lack of contextual relevance for that matter. I'm also very conscious of the time remaining, so I want to quickly again zoom out a little bit, and perhaps some might argue that this conversation that we're having right now around generative AI, around user-centered design, about algorithmic values and optimizing models is also a luxury in the current public health ecosystem, right? Where we do see that the system is still struggling with very basic infrastructure issues. And perhaps, Smriti, Shri, I wanted to bring both of you here in terms of how do we then hold both these things true, right? Think about state of the art technologies while also focusing on this behemoth of the question that we've had since independence almost, and the legacy issues that we have in the public Indian healthcare system. If you want to share your views on this, on the very nature of the discourse we're having.
No, I think
Smriti,
this
do you
is,
want to go?
yeah.
Oh, sorry, Shreya, of course. Please go ahead.
Go ahead, Shreya, since
Uh,
you started. Yeah.
I would say this is a perfect time to have this kind of conversations, even though it might look luxurious when we look at certain ground realities. We are still at a design phase where we still have influence to design, influence the designs of many of the systems which are getting out there. And also certain frameworks, regulatory framework about evaluations are still kind of, evolving in our country. So to have this discussion at this point of time is actually very optimal. Uh, if we can kind of, come out with right way of doing things for evaluations or for product design or from ethics, stigma, many other things. I think it would do a great benefit to the public health systems in our country. The second point about you know. I understand that there are still certain basic necessities which are still not met. I'll give you one example, like health worker motivation. That's a basic necessity of running a program. Can we think of new technologies to overcome certain, chronic problems which are we are trying to deal with decades and decades? And can we think of certain solutions which can really create, a groundbreaking solution to these chronic solutions? I think it is. I don't see any contradiction between the current situation and very aspirational tools which we have. I think we can still arrange wedding of both those and come up with something interesting.
I would just add that, I think you're absolutely right. There are institutional state capacity, all of those, realities which we must grapple with alongside thinking of technology as a solution. But we do see that even in the policy circle, in the conversation around AI and healthcare, it's so often that, if you're thinking about something like explainability, the discussion will get so technical and complicated around, is it possible to explain? If not, like, what happens? But something more basic than that, just the fact of that, the redress systems don't work. So just very basic procedural problems which you can solve without getting into explainable AI, etc. At the ground level, if there is a problem when dealing with a person, is there technology to solve for it? Something very basic like that. We don't, because it's just not, I guess, attractive to have that conversation. It's a dull problem where maybe AI is not the solution. So we kind of shove that problem aside and end up focusing much more on, the AI centric conversation. But I do think, yeah, especially in the civic tech sense, when we're deploying technology in the public sector context, we do need to think both about, the implications of technology and thinking about regulating that, but also the more dry subject of the procedural and the dull aspects around how to improve just that part.
Absolutely, Smriti. And that's exactly what I also wanted to point out, that perhaps GenAI as of now is like a very sexy topic. There's many panel discussions and not just this one around generative AI, but there's real merit in going back to some of those old age conversations that we've been having for decades, and perhaps we haven't really found a solution yet in terms of real world deployment. Maybe what I can do is take a minute and go around the table for some closing remarks, particularly if there's one statement that you want to make around what kind of a shift would you really want to see from where you are as of this sort of from a technical perspective, from a clinician perspective, into how generative AI is currently being integrated into the larger healthcare ecosystem. And with that, we can perhaps close. Alpin, do you want to go first? We can perhaps do it alphabetically.
Okay, I'll just make it really brief. I think, as I've said before, I think it's the humans behind the AI that need to take the right decisions. So the shift that I'd like to see is to make sure that the humans who are deploying AI understand it and deploy it responsibly, so that it's used as a tool and not as something that sort of consumes the person using it.
Amrita?
Very similar sentiment. I think AI can be a tremendous force for good, but it needs a more mindful approach, where you adopt a human-centered approach that's rooted in real problems and real needs. So yeah, that's it.
Super. Smriti, do you want to go ahead?
Yeah, I would just highlight the importance of an interdisciplinary perspective in all of this, from the book that we were working on, Private and Controversial, just the term surveillance, it means such different things for privacy advocates and for the public health professionals, right? One sees it as this very valuable, essential thing that you need to do your job, and one sees this as something which is, detrimental to civil liberty. So those conversations need to happen for us to, proceed. You have to have that common vocabulary, which can only happen if you have interdisciplinary conversations.
Shrek, any parting words?
Humility. I think we all need humility. I think that would go a long way.
So I think with humility, a very grounded approach to how we approach design generative AI systems, as well as interdisciplinariness, and of course, the larger phrase for the day of ensuring that there are humans in the loop when it comes to deployment of AI systems is also actually a good summation of the discussion we've had today. And thank you so much, everybody, for your time here, for sharing your insights also so generously. And I hope that this is just the beginning of such conversations, and that we will perhaps continue to have more such discussions, whether it's through speculative fiction or through these panel discussions around these critical aspects. But thank you so much, everyone.